So just to summarise how radiotherapy may have a place in regard to the other treatment modalities, we don't have any medical oncologists to question me here tonight, but this is the data from the 2 randomised trials of chemotherapy that have shown some benefit in mesothelioma patients, but unfortunately the benefit is not very high. This one was the Vogelzang study using pemetrexed and cisplatin. This was a European study which used Raltetrexed and cisplatin. Raltetrexed isn't manufactured anymore, but both of these large studies showed that the median survival benefit was only 3 months in these cases. And if you look at all the data on publications of patients who've had chemotherapy, unfortunately the best available chemotherapy, which is pemetrexed and cisplatin, has a partial response rate of about 25%, progressive disease in another 25%, and half of the patients have stable disease, which on average only lasts for 6 months. Now, there is the odd patient who has a complete response, and I thought I'd just show you one of those patients who we treated in Melbourne. This man was 56. The first PET scan he had was this one, and you can see just how bulky the disease is. We obviously rejected him from surgery and radiotherapy. He had 6 cycles of chemotherapy, and 6 months later, this is his PET scan. He had an amazing response. His pain disappeared. You can see that there's hardly any FDG uptake in the whole of the original area, and we debated whether it was enough to leave it alone or do something further with that. What we decided to do was a pleurectomy decortication, and when we examined that, there was residual disease over the pleura, particularly in the costophrenic recess, but because he was asymptomatic and we thought if the disease had come back, he would still benefit from further chemotherapy, we opted to observe him. We observed him for over a year, and then you can see as the PET scan was performed, the disease crept back. And when it got to this point, we decided he was getting symptoms to give him chemotherapy. He had 4 cycles of the same chemotherapy that he'd had 2 years earlier, and he had no response whatsoever. So we gave him some radiotherapy, but unfortunately it was a very rampant disease, and he died fairly soon after that. The histology was the same. We had tissue from here, and from here, and it hadn't changed. So even the best cases treated with chemotherapy, unfortunately, will inevitably relapse at some point in the future. The story with surgery, I'll address quickly here. These are some data from the series in New York from Flores, showing that although there's been no randomised trial, looking at large numbers of consecutive patients show that there's very little advantage in pneumonectomy compared to pleurectomy decortication. And if you break it down into patients who have those 2 procedures with or without multimodality treatment, there seems to be a significant advantage if you can add either chemotherapy or radiotherapy to surgery in large numbers of these patients. Now, this series was done from 1990, so it's a large number with various changes in treatment options over the 20-year course of time spanned by this. But it shows that there may be an advantage over surgery if you add another form of effective treatment. This is the data looking at the side effects of these 2 procedures in large numbers of patients. Obviously, if you do a pneumonectomy, the mortality and morbidity is higher than if you do a pleurectomy decortication. The survival appears better in the latter group, who are more likely to recur locally, whereas the group who have pneumonectomies recur more frequently distantly. And this is the group that now receives radiotherapy, whereas this one doesn't in most centres. There has been one attempt to do a randomised trial looking at the question of how effective is pneumonectomy, and that was from the UK, the Mars trial, which finished accrual 2 years ago but hasn't yet been fully published. And what they decided to do was assess 50 patients with potentially resectable mesothelioma and give them all chemotherapy to start with, and then randomise them so half of them would have a pneumonectomy followed by radiotherapy and the other half would just be observed. Now, I think that the result of the study is going to show no difference in the 2 arms. What has been reported is that there was some mortality from surgery, so that of the 24 patients who were potentially randomised, 5 of them didn't go on because the tumour had progressed on chemotherapy, and only 7 of the EPP patients were fit enough to be referred for radiotherapy afterwards, which also had its own morbidity. There is another attempt to reintroduce a new trial in the United Kingdom, and there are discussions being held at the moment about this, and it looks like sometime next year there'll be a trial which looks at giving cisplatin and pemetrexid-based chemotherapy, followed by, instead of pneumonectomy, pleurectomy decortication, again versus no surgery. And I'm not quite sure what questions they have to answer with this trial, but I've suggested to the PI that we may have an answer to another question if we give radiotherapy to the hemithorax of patients on both arms to see if we're able to at least improve local recurrence. But that's something to be looked at in future. The other question that arises from my results is that maybe because of the toxicity from doing a pneumonectomy, there may be a role in selected cases to give high-dose radiotherapy to the intact lung if they're not suitable to have the lung removed. And I thought I'd show you some data on local recurrences and whether there may be a difference in where the tumour occurs if you don't remove the diaphragm. So in the New York series, the site of first recurrence in patients who had pleurectomy decortication was that 2/3 recurred in the chest here and 1/3 recurred in the abdomen. But in the group who had the pneumonectomy, 2/3 recurred either in the abdomen or in other sites, and only 1/3 recurred in the chest. And whether this is due to the surgery removing the diaphragm is still speculative. But there was a series presented from Ruffini in one of the Italian centres at a recent conference in Kyoto, where they did a multivariate analysis of patients who had these two procedures, but some of the EPP patients didn't have the diaphragm removed, and some of the PD patients had it removed. And when they looked at relapses, whether locally or in the abdomen, depending on what surgery they had and whether or not the diaphragm was removed, they found that removal of the diaphragm didn't impact on overall survival. And the recurrences in the abdomen were certainly increased in the patients who had both operations if the diaphragm was removed. Now, there is a lot of morbidity and possibly mortality from taking out the diaphragm, and the position at the moment is that with effective high-dose intensity modulated radiotherapy, we're able to sterilise any residual disease after surgery on the diaphragm, and indeed in some of our patients who have had no surgery at all, we can still deliver a high enough dose to arrest the disease without causing any major side effects, even if it's on the right side and involves the liver. So just to conclude, I'd like to suggest that this data that I've shown you tonight shows that mesothelioma is a sensitive disease to radiotherapy, and high-dose radiotherapy is effective for both long-term regional control and palliation, and that IMRT is the preferred technique to deliver high-dose hemithoracic radiotherapy and can be safely delivered with or without a prior pneumonectomy in experienced centres. Thank you.